at Indiana Rural. I'm Amna Anwar. I am a Senior Director at Indiana Rural Health Association. And as of September of 2022, I took over as the Program Director for the Upper Midwest Telehealth Resource Center. For this presentation, I have with me my colleague, Danielle Rankley, who is a Program Coordinator with the Upper Midwest Telehealth Resource Center. And she will take a deep dive into the local legislation for the state of the region. Now, the agenda for today's webinar or the presentation includes 4 items. For the first one would be the introduction to the Upper Midwest Telehealth Resource Center. I'm hoping all of you that are here know about UMTRC or the Upper Midwest Telehealth Resource Centers, but if you are new or if you have joined after a long time, we can provide you with a refresher. Then we will also give you some policy and legislative updates as we prepare for the end of the PHA. We will also go over the CMS's physician fee schedule for 2023, and then Danielle will take over and provide you with the updates of the local legislation in the states for the Upper Midwest Telehealth Resource Center. The Upper Midwest Telehealth Resource Center, or the UMTRC, has been in existence for more than a decade. It is a part of the federally funded program. You saw that disclaimer on the first slide. We are a Health Resources and Services Administration funded program. We cover the states of Indiana, Ohio, Michigan, and Illinois. The rest of the states are covered by other TRCs. So there are 12 regional TRCs, and then there are 2 national TRCs as well. And all of us work together very collaboratively to provide you with the technical assistance with anything and everything pertaining to telehealth. What we do, so we are sort of like one-stop shop for all things telehealth in the states that we're in. We provide you with individual consultation. You can reach out to us via different layers, and I'll go over them in the subsequent slides. We provide technical assistance, whether it has anything to do with the reimbursement, with the technical solutions to your telehealth needs, or anything else pertaining to telehealth. We can provide you with the technical assistance for that. We also serve as connections to other telehealth programs, getting you connected with successful telehealth programs in your region or nationally. And we also provide updates, continuously updating our website for the reimbursement in each of our states that we're in. We do quite a bit of outreach when it comes to anything pertaining to telehealth. A few avenues that we utilize include our monthly webinar series. We also have a podcast by the name of Virtual View, where we have 2 new podcasts almost every month. We can also be reached via our virtual office hours, as well as the workshops that we hold in our states, and we're currently planning for those. Ways to stay connected with us include our newsletter. We don't really fill up your mailbox with a lot of information or newsletters. We have 1 monthly newsletter, and you can sign up for that by going on to our website at umtrc.org. And at the bottom, you can sign up for the email communications where you get the newsletter. Our newsletter includes information about the policy and the legislative updates, as well as anything new happening in the telehealth world in our region. We also have some other resources in our newsletter, which include the latest research for telehealth in the region and nationally or even internationally. As I mentioned in the previous slides, we do hold virtual office hours. This month, we are not holding them as we have the state of the region, and the entire team for the UMTRC, with an exception of few, are not on this call. But we do hold these. These are unstructured, so you can hop on using the Zoom link that is available on our website. The next one coming up will be on February 23rd. The time is 11 a.m. This is the Eastern Standard Time, since we are in Indiana. And please, you can jump on, ask questions, and if we cannot find immediately an answer to your question, we will reach out to the experts and get back to you with the answer that we find. Some of the projects that UMTRC is currently involved in, the first one is the resource survey that we are sending out through our newsletters. We want to know what our stakeholders what our stakeholders think is important in terms of us providing them with the services. So you can use that link if you have any topics of interest that you want us to cover via our webinar or workshops. Please use those links and we will try to get the experts. And if we have the expertise in-house, we will provide you with that information and create those webinars. Then we also have the webinar series where if you want to present on a topic, you are more than welcome to do that as well. You will have to fill out that survey so that that gets to our team and we can select the topics and the presenters. The best way to reach us is the email, which is info@umtrc.org. In order for your technical assistance requests not to get buried in our email, this is the best email to reach out to us so that you get your answer in the most efficient manner. Telehealth Locator is another project that I'm really personally excited about. This is a project that the UMTRC is working in collaboration with other TRCs. The idea is to present a dashboard or a mapping tool for the consumers where they'd be able to locate the telehealth providers. There are going to be different layers to this dashboard. The first one that we are working on is the grant writer dashboard, in which if you're writing a grant for telehealth, you should be able to look up the telehealth providers in your area or any telehealth deserts that occur, or if there are any specialties that you're looking for in a specific area while writing your grant, you should be able to access that. Currently, we're in the process of data validation. We have collected the data on the telehealth providers in our 4 states, and other TRCs have done so in their states. And we are validating if those services are still being provided by those providers so that when we go live with our map, we have the most up-to-date information, and we'll keep you posted. As of now, if you are a telehealth provider, use the link that is available on these slides when they would be shared with you, or on our newsletter to complete the online form, just so that we know that the telehealth services that you are providing and our data is complete. Ways to connect with us. Obviously, we have the website, the umtrc.org, and then there is where you can also access our podcast, The Virtual View. You can search for UMTRC on the YouTube because we have a YouTube channel, and all of our webinars are recorded and archived on our YouTube channel. So if any specific topic interests you, you can always go back and take a look at that. So we have social media presence through our Facebook and Twitter handle, and then we're also available on LinkedIn. So there are many avenues where you can reach out to us, and we'll get back to you as soon as possible. As I mentioned, UMTRC covers the 4-state region, which is in this lilac states covered, which include Illinois, Ohio, Michigan, and Indiana. But the rest of the states are covered by 12 regional telehealth resource centers, as you can see, and the 2 national, Technology Telehealth Resource Center and the Center for Connected Health Policy. All of us work very collaboratively and have created a consortium that's called the National Consortium for Telehealth Resource Centers. Their website is the NCTRC website, is the telehealthresourcecenter.org. All of us with our different areas of expertise contribute to the different resources that are available on the NCTRC website. And they also have a webinar series where most of the TRCs participate and present on various different topics. So that's also a very good avenue if you're looking for specific expertise pertaining to telehealth. For UMTRC, in the past and even now, most of the technical assistance queries that we receive are pertaining to billing resources and reimbursement. For the UMTRC, we have the telehealth reimbursement summaries for all of our states, which are available on these links. We try to keep them as updated as possible. You can reach out to our website and access these resources. And if you still have any questions, like I said, you're more than welcome to reach out to us using any of the means that I mentioned earlier. Now, that was us, the Upper Midwest Telehealth Resource Center, and now I'm going to dive a little bit into the public health emergency, the policy and the legislative updates, which came into effect during the PHE, and what will stay, what will go away, and what changes are permanent. We're going over them. Now, the telehealth, for those of you who were practicing telehealth even before COVID-19, the entire spectrum of the telehealth services and the locations which were eligible was quite different. During COVID-19, Medicare and Medicaid issued some waivers, which allowed the telehealth services to be provided to a variety of modalities as well as locations. So the changes that occurred in Medicare, just an overview of these, is that the geographic limit and the site limitations were waived. The provider list was expanded and approximately 80 codes were added for Medicare in terms of eligible services. Visit limits were waived and modalities phone was also added with audio only services. And then there were also the supervision requirements and licensing requirements which were waived. More codes were eligible for phone and some of the additional providers like the physical therapists, occupational therapists, the SLPs, and other users. So there was a lot of relaxed relaxations in the provision of the telehealth services and reimbursement that took place in Medicare. And Medicaid also kind of followed through with Medicare, in which the modality, location, and consent had relaxed requirements. Like modality allowed phone, location allowed home. There were providers that were added to the list, and licensing requirements were also waived. So there were a lot of things that made the delivery of services through telehealth to the patients who were obviously not able to go in person to receive those services during COVID-19, still had access through telehealth. There were some legislative changes that occurred during COVID-19 are the PHE, and then there are certain administrative changes through CMS, which came into effect as a result of those legislative changes. So the main legislations which impacted the delivery of the service during the COVID-19 and beyond included the Consolidated Appropriations Act of 2020. There was a Budget Act of 2022, and then most recently, and which has everybody excited and apprehensive at the same time, is the Consolidated Appropriations Act of 2023. And we will go over each of these, and then we will also go over the physician's fee schedule and what is in there for 2023. Now, the Consolidated Appropriations Act of 2020 was not very vast when it came to telehealth. It had a very special focus, and that was the behavioral health and the mental health services to be provided in home without the geographic requirement. But this had a specific requirement attached to it that this was possible through telehealth if certain requirements were met, and that requirement was that the telehealth provider providing the mental health services should have had an in-person visit with that patient 6 months prior to that visit. And then the Budget Act of 2022 actually created a grace period of 151 days post-PHE for some of the waivers or the extensions which were in place during the PHE to be extended through that 151-day grace period. Now, the Consolidated Appropriations Act of 2023 now extended that grace period even further to the end of December 31st, 2024. So I'm going to go over some of the things that were more, I would say, that pertain to telehealth during the Consolidated Appropriated Act of 2023. Again, it had to do with location. It suspends the geographic requirements and allows the home to be an eligible site. And it continues to allow some providers which were added, like the physical therapist, occupational therapist, the speech pathology, language and pathologists, and audiologists to serve as the eligible providers. It also allows the FQHCs and RSCs to continue to provide the services via telehealth and continue to serve as originating sites. It allows audio only to be used to provide some services. And it delays the implementation of the permanent policy regarding the mental health and services, the in-person visit requirement. It delays it till December 31st, 2024, so that that requirement for the in-person visit prior to the telehealth visit, 6 months prior to the telehealth visit, will not come into effect until January 1st of 2025, according to this act. One thing that it did, which is slightly different, is that it requires a study on telehealth that would look into the data that is gathered between 2022 to 2024. And then the interim report will be due in October, and then the final report in April of 2026. The idea is to see the efficacy and the utilization of the telehealth during the time period where pandemic was not necessarily impacting it, because at the end in the early 2022, the in-person visits were also started at many of the healthcare facilities, and this data will be more applicable to the everyday use of telehealth when there is no pandemic or public health emergency. One thing that it did was that extension of the safe harbor for the absence of the high deductible of telehealth for the high deductible plans. So including that can be paired with the health savings account. What it did not do, it does not include the extension for the waiver that currently allows the healthcare providers to prescribe the controlled substances via telehealth for the substance use disorder treatment. So those waivers, which were allowing the telehealth providers to prescribe the controlled substances via telehealth, will come to, it has not extended those up until December 31st in 2024. And it does not direct the DEA. It does direct the DEA to implement that special registration process so that once the providers are on that registry, they'll be able to continue to provide the telehealth, the controlled substances through telehealth. But DEA has been asked to do that for quite some time, and they have not really taken any step towards it. So we don't really know. Like, although this act is asking DEA to do that, we don't know when that would actually take place. Another thing that the Consolidated Appropriations Act of 2023 did was that the expiration of the continuous enrollment into the Medicaid and the receipt of the temporary FMAP increase will no longer be linked to the PHE. So for now, the PHE has been extended up until April, but the continuous medical enrollment that was taking place during the PHE, in which the patients did not have to go through the recertification process, and also the increased FMAP, which made more individuals eligible for Medicaid, is not linked to PHE anymore. It will go away on March 31st of this year, and starting April 1st, the states will be able to terminate the Medicaid enrollment for individuals no longer eligible. Although this is not directly related to telehealth, but people losing their Medicaid eligibility will impact their ability to receive services through telehealth, as well as the provider's ability to continue to provide those. So that is something that the states are keeping a close eye on, but the unwinding of these waivers will start April 1st, where the states would be able to kick the people off of Medicaid until they are recertified, or if they're no longer eligible, then they would no longer be able to have Medicaid. So this was a legislative act. Now, moving on to the administrative side of the things, which actually is CMS, which releases this physician fee schedule every year. And obviously this year we have the physician fee schedule of 2023. Now, when this physician fee schedule was released for comment back in July, what CMS had done was taken into consideration the Consolidated Appropriations Act of the Budget Act of 2022. So it was most of the things that were recommended with the 151-day grace period in the Budget Act was then included into this physician fee schedule with slight variations, like some things that were not included. But the Consolidated Appropriations Act of 2023 was passed in December over the holidays, and it's only January 24th. So as of now, CMS has not taken any action to align themselves with the Consolidated Appropriation Act of 2023. The information that is available is aligning with the Budget Act of 2022, and we will keep you updated. I will go through the physician fee schedule, and if you have questions, we'll take a break after this regarding the federal legislation, and you can ask those questions. So like I said, the CMS releases this physician fee schedule every year. It came into the one that was released for comment on July 7th, was finalized in November, and then it came into effect on January 1st of 2023. There are certain telehealth provisions which were included, which, like I mentioned, aligned with the Budget Act of 2022, which included that the FQHCs and the RHCs and those providers, physical therapists, occupational therapists, audiologists, speech language pathologists, they remain eligible providers to be reimbursed by Medicare if they provide certain services via telehealth during the grace period. So this is only for the grace period of 151 days. Post PHE. Remember, current PHE ends at in April. If this is the last extension, then in February, the White House will announce that the PHE will end in April. However, there can be at least, like, there is speculation, one more extension, but we're not really sure at this point. Other thing which the physician fee schedule does is that, again, home is an eligible site when receiving the services, and the geographic limitation would also not apply during the 151-day grace period. Policies around the provision of mental health via telehealth that were put into law by the CAA passed in December 2020, and the administrative policies are again delayed through 151-day grace period. The temporary telehealth eligible services, if you are not familiar, there are different categories of codes. The category 3 is the temporary eligible services. These are the codes which were placed into this category, and they were not added to the permanent category, which is category 1, and they will remain eligible to be billed for telehealth services during the 151-day grace period. Adding to the permanent telehealth list. So these will be, these were added as permanent telehealth list codes, and they were GXX1 and GXX3, which is the inpatient and hospital remote monitoring, or at home long-term monitoring of the patients. They were added to the permanent telehealth list codes, and these would replace the 99356 and 99357. They clarified. Now, this is where the confusion has arisen, and if you have any questions, let me know. CMS, through their physician's fee schedule, clarified that they will not be adding the telephone codes 99441 to 99443 to category 3. But will assign the bundle status to these codes after the PHE and the 151-day grace periods ends. So these codes can still be used for reimbursement up until 151 days grace ends post PHE, but after that they will be included in that bundle status for reimbursement for the services that are provided during that visit for the patient. During the 151-day grace period, the modifier 95 should continue to be used, but after this, the point of service code 02 and that 10, whichever is appropriate, whether the patient is in home or is at site other than home, should be applied. The billing for the audio only modifier beginning of January, like this January 2023, modifier 93 should be used for audio only consults. And previously CMS had directed that FQHCs and RHCs and the opioid treatment programs to use the FQ as their modifier for audio only, but now they're directing even them to use the 93 code for audio only services. That they're also saying that FQ or 93, both are appropriate, at least during this grace period, to be used as the modifiers. Now, the other thing which the physician fee schedule has mentioned is that it will continue to allow the opioid treatment programs to intake add-on code to be furnished by live video, audio only if not available to the beneficiary when they bill for the initiation of treatment with buprenorphine to the extent authorized by DEA and SAMHSA. Again, telehealth facility fee for this is $28.61, and there are remote therapeutic monitoring codes which are added. More detail about the physician's fee schedule for 2023 is available at this link which has been created for the Center for Connected Health Policy, the National Telehealth Resource Center. And they have all the information with codes and lists available, which I did not go through. I just kind of like highlighted the main things that are in that physician fee schedule. Now, to go over kind of like brief summary of what we went through. The permanent telehealth policy, which is not dependent upon the PHE and it will remain in place, is the use of the telehealth to take place in specific geographic locations and sites, mostly medical facilities. So that was in place and that will remain in place. The permanent telehealth policy primarily allowed only live video. There was a limited list of providers that were eligible to be reimbursed through telehealth, and mental health services provided without geographic requirements and in-home and audio only can be used if certain requirements are met, like prior in-person visits. Now, these are permanent. We're not talking about anything that is happening during the grace period or anything that the Consolidated Appropriations Act of 2023 did. FQHC and RHC allowed the use of live video and audio only for mental health visits, and then prescription of the controlled substances. There are very narrow exceptions which were already in place before COVID-19. They will continue to be in place post PHE as we move out of the waivers or the extensions which were implemented during the PHE. What automatically goes away, and this has nothing to do with 151-day grace period, as on the day that the PHE ends, the next day, these will go away. This is the HIPAA relaxations, which were announced during the COVID-19, and then which allowed many of the providers to use non-HIPAA compliance circumstances, or there was some relaxation when it comes to HIPAA compliance in terms of providing the telehealth services. These are going to go away. They will not be, that grace period will not have these waivers extended. So the HIPAA compliance will come into effect the day the PHE ends. And then the exception of the prescription of the controlled substances, that will also go away immediately after the PHE ends, because none of the legislative actions or the CMS's physician fee schedule has made any changes pertaining to the prescription of the controlled substances. Now, post-PHE through the December 31st of 2024, I have to make a change in this slide. I'll do that before sending it out. It's December 31st, is according to the Consolidated Appropriations Act, this should be in place with Medicare. The geographic limitation is temporarily suspended. Home continues to be an originating site. We can continue to use audio only to provide some services, just not just the mental health services. Again, FQHCs, RHCs, and all those other providers will continue to be eligible. The in-person visit requirement for the mental health visit continues to be suspended, and the COVID list is eligible services, that 151. But as of now, CMS has not taken any action. So that list is only, according to the CMS's physician fee schedule, is eligible up until 151 days grace period post PHE. It gets confusing. What the consensus is, let me go to the next column and I'll go back to this, is that post PHE through the end of the year, the PHE ends. So if PHE ends in 2023, it will be December 2023, the Medicare Category 3 services, virtual presence of direct supervision will be in place, will be waived. So the discrepancy which right now occurs is the extension of the 151-day grace period by the Consolidated Appropriations Act of 2023 and the CMS schedule is, because CMS has not had time, it's only been like 24 days since the physician fee schedule came into effect, to align themselves with the Consolidated Appropriations Act of 2023. So the general idea or consensus among the experts is that CMS has plenty of time, since the PHE has been extended up until April, and then they also have that 151-day grace period to align themselves with this new policy. But as of now, where we currently stand is that the 151-day grace period and everything that comes with the physician fee schedule is still in place until CMS makes those changes. Anything that is in the Consolidated Appropriations Act would not be applied, although it's in the legislation, but the administrative side has not taken action for it to be applied for the reimbursement for the providers and how to code for that and all of that. So right now, let's stick with the physician fee schedule and the 151-day, and we'll see if the PHE gets extended. But the common idea is that CMS will eventually align themselves with the Consolidated Appropriations Act of 2023, and everything will be extended. But as of now, they have not done that. Some good news for the people who are a little bit concerned, not a little bit, a lot concerned about those the eligibility of the controlled substances being prescribed and through telehealth services, is that there is a proposed rule by SAMHSA which makes permanent initiation of buprenorphine via audio only or audiovisual telehealth if the OTP physician, PCP, or an authorized healthcare professional under the supervision of the program physician determines adequate eval can be done via telehealth. So that is proposed by SAMHSA. We'll see if any action is taken over it. And then another thing which CMS clarified through a letter was e-consults. So the Medicaid, they noted that the Medicaid will continue to reimburse for the e-consults, but it is not mandated by CMS. So Medicaid can continue and can get reimbursed for that, but it is not necessarily mandated. So before moving into the local legislation and the updates, I will take a pause here and open it up if anyone has any questions. Hearing none, I will hand it over to my colleague, Danielle, who's going to take a deep dive into the local legislation of the states that we are in. Danielle, I'll forward the slides for you. Just let me know.
Great. Thank you, Amna. Hi, everyone. Thanks for joining us today. So we'll get started going on local legislation state by state. So we'll start off with Illinois. So a quick overview of the current status in Illinois. And because we're still in the public health emergency, if you attended our last State of the Region, not much has changed here, so I won't spend too long on this. But so far as Medicaid reimbursement goes, live video is reimbursable, store and forward in Illinois is not. Remote patient monitoring is with some restrictions. Again, audio only is again with some restrictions. Private payer laws, they do exist, and Illinois is unique in our region because it is the only state with explicit payment parity within those laws. So some information about professional requirements. So the licensure compacts that Illinois is a part of, it's part of the Interstate Medical Licensure Compact, also SIPACT, and now to FQHCs. So FQHCs do originate sites explicitly allow for live video. Yes, they do. Distant sites also explicitly allowed for live video. Yes. Store and forward is not explicitly reimbursed. Audio only is not explicitly reimbursed. And they are allowed to collect PPS rates for telehealth. So that's a quick overview of what's going on in Illinois right now. So Amna, if you could go forward. And again, this is just some more Medicaid policies. Not much additional from what we just went over, but they do reimburse for live video for telemedicine and telepsychiatry services for specific providers. And Illinois Medicaid will provide reimbursement for home uterine monitoring, continuous glucose monitoring, and some audio only services too. So again, if you want to see the full list of these, you can follow the link here because we will be sending out these slides later. And an Illinois specific information. So the Illinois public health emergency is still going on. The governor has issued his 38th COVID-19 disaster proclamation. So that has been extended in Illinois only through February 5th, 2023. So next slide. So we're going to go through a couple pieces of pending legislation for each state that are important to keep an eye on just related to telehealth. So first up, we'll go through SB 48, and that is the Medicaid Telehealth Services Bill. And that amends the medical assistant article of the Illinois Public Aid Code and allows for vendors who exclusively practice telehealth to enroll in medical assistance programs within the state, even if they're not physically located in the state, as long as they are licensed to operate within the state. So this is something that was recently introduced like 4 days ago. So it's still in its infancy, but important to keep an eye on in the future. Next slide. So HB 2554, So this is telehealth rules related to acupuncture. So this adds acupuncturist under the definition of a healthcare provider for telehealth. And this is something that is in first chamber now. So not quite enacted yet, but we'll keep you updated as to its progress. Now, SB 3168, and that's related to dental practices. So it amends the Illinois Dental Practice Act and provides that a person who uses teledentistry is considered to practice dentistry under the act. So it provides that a dentist may utilize and delegate dental service to a dental hygienist or dental assistant using telehealth only for supervision requirements as specified in the act for inpatient care. So it just adds teledentistry to those already existing definitions. So next slide. So, and this is SB 4015, and that's dietitian nutritionist. So it amends the definition of telepractice to include telehealth under nutritionist. So nothing fancy there, but we'll keep an eye on it. So next, HB 5711, and that is to do with telehealth services. And this is an appropriations act. So it is moving $9 million from general revenue to specifically be associated with implementing emergency telehealth services for all persons with intellectual and developmental disabilities who are receiving services under the Home and Community-Based Services Waiver Program for adults with developmental disabilities. So specifically an appropriations related to that. And this is HB 710, and this is the Cannabis Oversight Commission. And this would have to do with online prescribing and provider-patient relationship, and it prohibits the physical examination of certifying health professionals that may be performed by remote means, including telehealth. So this is just about medical marijuana. So we'll keep an eye on this one as well. All right, and that is all for Illinois now. So we're going to move into Michigan. And again, we'll do a quick overview, not spend too much time on this. So far as Medicaid reimbursement goes, like all states, Michigan does reimburse live video. They also do store and forward, remote patient monitoring, and audio only. All of those do have specific requirements, but in some sense, they do reimburse for those. And they do have private payer laws that exist, but they do not have payment parity spelled out explicitly. So Michigan is also part of the Interstate Medical Licensure Compact. And so FQHCs, they do allow originating sites explicitly for live video, as well as distant sites. Store and forward is not explicitly reimbursed. Audio only is explicitly reimbursed, and they are allowed to collect PPS rates for telehealth. And a couple of Michigan Medicaid specific policies. So they do reimburse for live video, as I said. RPM is a covered service for both acute and chronic conditions. Medicaid reimburses for asynchronous telemedicine services, including store and forward services, interprofessional telephone, internet, or electronic health record consultations, and remote patient monitoring services. And Michigan Medicaid also generally uses the term telemedicine or telepractice. So when you see things talking about telehealth in Michigan, it's generally going to be referred to as telemedicine rather than telehealth. So next slide. A recent law that was passed in Michigan, or wasn't recently passed, but is recently being enforced. So as of January 1st, 2023, there is a requirement that all Michigan providers electronically transmit all controlled and non-controlled substance prescriptions. So there are a few exemptions that exist. Veterinarians are exempt. And when electronic transmission is not available due to electrical or technical failures, it's okay to still dispense that prescription. Prescriptions also that are dispensed either out of state or have been prescribed out of state are waived from this. Also drugs that have been prescribed under a research protocol, and also prescriptions issued and dispensed by the same healthcare facility or by the same provider. So if you're both prescribing and dispensing, you don't need to electronically transmit a prescription to yourself. So you can see the text of the law for more information and a full list of exceptions, but those are going to be the most common ones. So Excuse me. So a couple of pieces of pending legislation from Michigan that we're keeping an eye on. So HB 5751, it's to do with animals. It defines telehealth in relation to the Emotional Support Animal Act. So that is something that is now defined and covered under there. So next slide. So HB 6446, and this has to do with health occupations. So this will establish the Occupational Therapy Compact for interstate licensure. So it's always exciting to be looking at interstate licensure compacts. So this is one that we will definitely keep an eye on and let you know as it moves through the whole process. Okay, and this is SB 79. This is an Appropriations Act. Nothing particularly noteworthy beyond the fact that it's going to appropriate funds to increase telemedicine capacity, among other things. So we will keep an eye on this as well. HB 5795, this is another Appropriations Act, various funds and appropriations for telehealth and telemedicine services. And you can see the bill for the full information, but it's mostly to do with where money is going. SB 828, another appropriations. So there's a lot of bills going around that have to do with funding for telehealth, I think is the takeaway we can take from this. This is one, HB 646. Ooh, I'm so sorry. I think I added this slide twice. This is again, the Occupational Therapy Compact. So HB 6355 having to do with health facilities. So this permits the use of telehealth by a clinically qualified individual that they may perform the assessment for the hospital or hospital as that term is defined. For community mental health services program, crisis stabilization unit, or any other entity under contract to perform, if the pre-admission screening unit is unable to complete the assessment within 3 hours after the notice described in the subsection. So this just will allow for telehealth psychological evaluation if certain conditions are met. Okay, and moving on to Ohio. And a quick explanation of what's going on in Ohio. And again, it does allow for live video, store and forward, remote patient monitoring, yes, 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 as well as audio only. And like all states, there are some specific exclusions that do apply. But for private payer, the law does exist, but payment parity does not exist. So professional requirements, a couple of licensure compacts, so they are part of the LPIC, the CC, the IMLC, the NLC, OT, SIPACT, and PTC. So Ohio is part of a number of licensure compacts. So FQHCs, originating sites explicitly allow for live video, no. Distant sites explicitly allowed for live video, yes. Store and forward is not explicitly reimbursed, nor is audio only, but they are allowed to collect PPS rates for telehealth. But again, there are some exceptions there. A couple of Ohio Medicaid policies to highlight. They do reimburse for live video telemedicine. So far as store and forwards go, conversations or electronic communications between practitioners regarding a patient without the patient present is not considered telehealth. So that particular circumstance is not going to be considered telehealth unless the service would allow billing for practitioner to practitioner communication in a non-telehealth setting. So consults cannot be billed as telehealth unless it's something that would be able to be billable even outside of a telehealth setting. So important to note that. So remote patient monitoring, remote physiological monitoring codes are listed as a covered telehealth service. I won't read out all those numbers for you, but you can find those there. Remote patient monitoring will be paid through FFS as a covered non-FQHC/RHC service under the clinic provider type 50. So just a couple of nuances there. And a couple of pieces of pending legislation from Ohio as well. So Bill SB 9, that's going to revise medical marijuana. So it allows a physician certified to recommend treatment of a qualifying medical condition for medical marijuana to make that a recommendation via telemedicine. So that is something that has just recently been introduced. So we'll let you know as that moves forward. So HB 203 requires occupational license if experienced in another state. So that is just to do with licensure. SB 364, licensed certified mental health assistants. So that just has to do with the licensing requirements around mental health assistance in regards to telehealth. And now, but last, but certainly not least, my home state of Indiana. So we'll go into this a little bit. So quick overview. It does allow for live video. It does not allow for store and forward, remote patient monitoring, yes, and audio only, yes, with certain exclusions and rules and regulations. Private payer laws do exist, but payment parity does not. A couple of the Indiana licensure compact, ASLPIC, EMS, IMLC, NLC, SIPACT, and PTC. So FQHCs, they allow for explicitly for live video. As for originating sites, no, they don't. Distant sites explicitly allow for live video, yes. Store and forward is not explicitly reimbursed. Audio only is, and they are to collect PPS rates for telehealth. So that's a quick overview of Indiana. Okay, and a few specific Indiana Medicaid policies. So Indiana Medicaid reimburses for live video. Indiana Medicaid does not reimburse for store and forward. Through store and forward can still be used to facilitate other reimbursable services. So that's important to keep in mind. Indiana Medicaid defines telehealth as including remote patient monitoring. So it has recently been expanded, and that's something I'm going to go into in future slides, but it must meet prior authorization requirements. So RPM is reimbursable, but only if it has been authorized beforehand. So, and also bills using place of service code that would have been reported had the service been furnished in person, and modifier GT via interactive audio and video telecommunication system. So that change only applies to professional claims though, so. Okay, so there have been a number of Medicaid updates recently coming from Indiana. So I won't go into these super in depth. I'm not going to read out all the codes for you, but to just in the short of it is that there has been an expansion of audio only coverage, and this became effective on December 9th in 2022. So in accordance with this bulletin, proper procedural codes and modifiers need to be used. And a few of those proper procedural codes can be seen on this screen now. Like I said, I'm not going to read through all of these, but when you are billing, it's important to have the proper procedural code attached. A few more of those Medicaid updates. So for certain telehealth services, an audio only modifier can be used to signify when a service is delivered via audio only telehealth. Intensive outpatient treatment IoT services will be reimbursed when rendered via telehealth, and you can see the link there for more details on what exactly that encompasses. And there have been some discharge and evaluation codes added related to hospital discharge day management, initial evaluation and management of a patient in a nursing facility, evaluation and management of a new or established patient in a rest home, and evaluation and management of a new or established patient within their home. So those codes are listed there. So a few more Medicaid updates. So the RPM changes. More providers can furnish and bill now, but like I said before, patients must meet certain criteria, and it does require prior authorization. So that's something that's important to keep in mind. Some additional codes have also been added effective for service dates on or after July 21st, 2022. So now, guidance regarding the rendering of applied behavioral analysis therapy services via telehealth are included in those. And then availability of skills training and development for eligible members who have access to Medicaid rehabilitation options, so MRO services, and clarification regarding on how outpatient claims for telehealth services should be billed. So more information on those things can be found on the Indiana Medicaid website, or you can follow up with us and we can provide more information should you need it. So a few more pieces of legislation, these ones coming from Indiana. So HB 1612, and that has to do with cross-state licensing, and it's adopting the counseling compact. So more interstate licensing compacts for Indiana to be part of. And HB 1352 to do with telehealth services, and this is to do with Medicaid reimbursement. This is something that was only introduced recently. So it provides that the Office of Medicare Policy and Planning may not require a provider that is licensed, certified, registered, or authorized with the appropriate state agency or board and exclusively offers telehealth services to maintain a physical address or site in Indiana to be eligible for enrollment as a Medicaid provider. Or a telehealth provider group that providers are licensed, certified, or authorized with the appropriate state agency or board to have an in-state service address to be eligible to enroll as a Medicaid vendor or Medicaid provider group. So the long and short of that is, if they are practicing telehealth within Indiana and they're licensed here, they don't necessarily need to have a physical address. So, and this is SB 36. That has to do with audiology and speech language pathology compact. So it would just be adopting another of those nice cross-state licensing compacts. Mental health, and this adds the application of telehealth statute to additional practitioners. So HB 141, I forgot to say the name. So HB at 1230, telemedicine services, and it expands the application of telehealth, the telehealth statute to additional practitioners. So it's just increasing the number of people who are considered telehealth practitioners. Okay, and so HB 1284. So this will require a healthcare provider who provides telehealth services to obtain written consent for the provision of telehealth services, requires a prescriber who provides telehealth services to conduct certain components of a physical examination and document the results in the patient's medical records. So this just has to do with prescribing again. So it allows a prescriber to issue a prescription for a controlled substance to a patient who is receiving services through the use of telehealth and who has previously examined, the prescriber has previously examined the patient in question. So it has to do with prescribing. So we will keep an eye on this one as well. So to keep up with these and other pieces of pending telehealth legislation, the CCHP, the Center for Connected Health Policy, they have a really great telehealth legislation and regulation tracking tool. So if there's any of these things I mentioned today or anything else you're interested in, you want to track the progress of those, you can visit the website to follow them for yourself. So they update that pretty frequently. So also, I mentioned the Interstate Medical Licensure Compact a few times because we are all in the UMTRC service area, part of that, with the exception of Indiana, which has passed it, but is still being implemented at this time. And the same for SIPACT. It has been implemented in all of the states except for Michigan, but the legislation has been introduced there. So it's important to keep an eye on these interstate licensure compacts because they can remove some barriers practicing between states.
Thank you so much, Danielle. And the last one is just some resources that are available that the Upper Midwest Telehealth Resource Center has created with other TRCs, and they're available through these links. You have a timeline for PHE, and then we're a part of creating a blog post for NCTRC for the HIPAA enforcement discretion that will end with the end of PHE, and certain other informations. Like always, if you have any further questions, you can reach out to us, Danielle and myself, using our email or the info@umtrc.org email, and we'll open it up to questions if you have any.
There are a couple of questions in the chat, Amna.
Oh, okay. Let me.
So starting with the earliest one, can someone comment on FQHC and audio-only reimbursement in Illinois? What does not explicitly mean? So not explicitly is going to mean that in the regulations surrounding that, there's nowhere has it been said explicitly that these services are reimbursable when provided through an FQHC. So I could provide some more specific information on that if you have a specific question on what services you're talking about, if you wanted to follow up with that. But when I say not explicitly, it just means it doesn't necessarily mean there's no circumstances. in which audio only wouldn't be reimbursed. It just means that there is not something that explicitly says it is, if that makes sense. Amna, do you have anything else to add to that?
I don't. I think there was another question about the extension of the Illinois disaster proclamation. I can send you the link. I actually was looking up this morning just to see the update, and I saw that. And I will send the link. I'll ask Caroline to send the link with the slides for that. The other question, I think, is for Illinois again, Danielle. Can you use audio only for telebehavioral health in Illinois?
I'm scrolling through my notes. I want to say yes, but if I don't know the specific circumstances, I can't say that 100%. But generally they do allow audio only reimbursement in Illinois under the particular, like the public health emergency that exists right now. But if you have a specific question about that, feel free to follow up with us and we can give you some more specific guidance.
Courtney provided us with the information. Thank you, Courtney, that the Michigan Governor Whitmer signed the inclusion into the SIPACT Act. So we will update our information at our end. Thank you so much for that. The other question is regarding Indiana. Are interdisciplinary consults reimbursed in Indiana? Are we talking about e-consults? That was Amy.
Provider to provider.
Okay, so e-consults.
Not necessarily. Could be audio.
Okay. Danielle, do we have anything on Indiana?
Nothing specific in my notes. That's something I could do a little bit more research on and follow up.
Thank you.
So we'll reach back to you, Amy, on that one.
Thank you.
I think the other one was also about the SIPACT. Should be effective in Michigan on March 31st, 2023.
Woohoo, good to hear.
One thing that I had mentioned, and I will just go over that regarding the audio only coverage that is right now, which the CMS, I'll go back to that slide. Hold on. Because there has been some confusion. Probably you guys are not confused since I did not get that question, but I just wanted to go over that. Let me find that slide. So the telephone evaluation and management codes of 99441 to 99443 to category 3, but they would be assigned bundle status after the grace period of 151 days will stay the same until CMS changes anything. So these codes are not that audio only services that the Consolidated Appropriations Act 2023 is mentioning in that law that will continue till December 31st of 2024. So the codes over there based off of the language that is in the law would be the telehealth services. And those are 99241 to 99275, 99201 to 99215. And I can send this information, and 90804 to 90809 and 90862. So this status for these specific codes, it will stay the same until CMS makes any changes. This is not impacted by the Consolidated Appropriations Act of 2023. They will move into the bundle status post 151 days of the grace period until CMS changes that. That was the only clarification that I wanted to provide.
Thank you so much.
Thank you. And like always, if you have any questions, you can reach out to us using our website and our email, and Amy will get back to you regarding your questions. Thank you. And Carolyn will be sending out these slides and you can access all the links that are available. Appreciate that. The next State of the Region will be in April, and we'll send more information regarding that. And hopefully we'll have more updates from CMS by then. Thank you.